Welcome, curious minds, to another deep dive. Ever wonder how reliable the public health statistics really are? Especially those ones that tell us why people die.
Yeah, it's fundamental stuff.
Exactly. We often see conflicting numbers flying around, and today we're going to unpack why that might be happening.
Hmm.
We're diving into a really fascinating 2006 paper by Johansson, Westerling, and Rosenberg. It basically scrutinizes the very methods other studies use to evaluate death certificates.
So it's like a study of the studies.
Precisely.
All right.
Our mission,
Yeah.
to figure out why their results are so contradictory and maybe challenge how we think about this foundational data. Get ready. So let's start at the beginning then. Why do death certificates matter so much? What's their, core role?
Oh, they are absolutely fundamental, especially for epidemiologic research. Think of them as kind of the bedrock of public health data. They give us crucial information on the cause of death, the circumstances around it, demographic characteristics of the person who died. This data feeds into everything. Public health policy decisions, medical research priorities, where we allocate resources.
Right. Understanding disease trends.
Exactly. Without good, consistent mortality data, we're sort of flying blind on a lot of public health fronts, making decisions without a clear map.
And the World Health Organization, the WHO, they really push for standardization, right, with the ICD system.
For over 50 years now, yeah. The International Classification of Diseases.
But realistically, is true global uniformity actually achievable, given all the local variations, medical practices, maybe even cultural things, or just tricky individual cases?
Well, that's a really critical question, and it's precisely what the WHO aims for with the ICD. The system meticulously lays out how cause of death info should be collected, how it should be coded, disseminated. The goal is high comparability, internationally and nationally. So a death from, say, heart disease in Sweden can, in theory, be reliably compared to one in the US.
So on paper, it sounds incredibly robust, very systematic.
It does.
Okay, so we have these stringent global standards, a system designed for, well, impeccable data. Yet, we know it's not always that simple in practice, is it?
Not at all. Despite these standards and, half a century of effort, lots of studies have shown that death certificates often aren't properly completed.
Really?
Yeah, we're talking frequent discrepancies, what's on the certificate versus what you might find in detailed medical records or autopsy reports. It's a well-known challenge.
But here's where it gets really interesting, according to this paper anyway. Even the studies designed to evaluate these discrepancies, the ones trying to figure out how accurate the certificates are, they often deliver conflicting results themselves.
Exactly.
So what does that tell us about the soundness of their evaluation methods?
That's the puzzle Johansson and colleagues really dug into. If the assessments of accuracy are all over the place, you have to start questioning the tools doing the assessing, right?
Okay, so our core paper's authors, Johansson, Westerling, and Rosenberg, they took on this, well, huge task of reviewing these evaluation studies, like evaluating the evaluators. How did they even approach that?
Hey, that's a good way to put it. They did extensive Medline searches, basically diving deep into this massive digital library of biomedical literature. Their focus was super specific. Articles published from 1998 onwards, looking only for studies that evaluated cause of death as reported on death certificates.
Okay.
After a really thorough screening, they ended up including 45 articles, which described 44 distinct studies. That was their data set. And crucially, they didn't just summarize them. They used a very structured protocol. They had specific points they examined across 3 key areas: how the data was collected in those studies, what review procedures they used, and, this is critical, how they identified the principal cause of death.
Right. That structured approach seems key to spotting the inconsistencies.
Definitely.
And their goal wasn't just summary. It was about assessing reproducibility. Why is reproducibility so vital here, especially with something as foundational as mortality data?
Well, reproducibility is just the cornerstone of scientific validity, isn't it? If a study isn't reproducible, it basically means another research team can't follow the same steps and reliably expect similar results.
Which undermines the findings.
Completely. So in their assessment, for a study to count as reproducible, it needed to meet clear criteria. First, clearly describe the review panel, who were the experts doing the judging. Second, have an explicit strategy for handling competing causes of death. We'll get into that more.
Okay.
And third, for studies looking at specific conditions like cancer or asthma, they needed explicit diagnostic criteria. Without those things clearly stated, you really can't trust the findings, you can't verify them, you certainly can't build on them reliably.
All right, let's get into what Johansson et al. actually found? Because some of these results are pretty eye-opening, frankly. What did they uncover about how these evaluation studies collected data and ran their reviews?
Yeah, the inconsistencies were significant. For starters, sample sizes were all over the map. Some studies looked at just 21 cases.
Wow, tiny.
Right, while others looked at over 10,000.
Huge difference.
And most used medical records, which makes sense, but some relied only on autopsy reports or police reports or even interviews with relatives or doctors. That variation in the source material itself immediately makes it hard to compare study results fairly. But what's maybe even more telling is the lack of critical assessment of the comparison material. The stuff they were using to check the death certificate against.
What do you mean?
Well, the quality of that comparison information, like how good were the medical records, was only formally graded in 26 out of the 44 studies. In 10 studies, it was just kind of vaguely mentioned in the discussion section.
And the rest?
Not mentioned at all in 8 studies.
Seriously? So how can you accurately judge something if the benchmark you're using hasn't itself been checked for quality?
Exactly. It raises big questions about the foundation of their comparisons.
So if I'm getting this right, we're talking about studies assessing quality, but without always doing their own quality control first.
Yeah.
That sounds fundamentally flawed.
It really does. And it doesn't stop there. Get this. The number of people reviewing the information wasn't even stated in 14 of the 44 studies.
You're kidding.
No. And even more concerning, only 6 out of the 44 studies reported doing any kind of reliability tests on their own evaluation procedures.
Only 6.
6, meaning the quality assurance for the evaluation itself was often just missing.
That's pretty wild. So studies evaluating accuracy weren't necessarily ensuring the accuracy of their own evaluation. Okay. And what about bias? Were the reviewers blinded? Did they know what the original death certificate said?
Good question. Not consistently, no. Reviewers were only blinded to the original death certificate in 15 studies. In 17 studies, they actually had full access to the original certificate while doing their review.
Which could influence their judgment.
Absolutely. And maybe worse, 12 studies didn't even state whether the reviewers were blinded or not. Crucial detail, just left out.
Okay, wow. But the paper suggests the biggest problems, the ones that really hit reproducibility and comparability, cluster around identifying the principal cause of death. This feels like the absolute core of it.
It absolutely is. This is the linchpin for reproducibility. So think about the 12 studies that looked at all causes of death, not just specific ones.
Okay.
None of them described how they handled competing causes of death.
None. What does that mean exactly, competing causes?
It means when several distinct, sort of etiologically independent conditions could plausibly have led to death, how do you consistently decide which one is the principal cause?
Right. Like you take an elderly person, they have chronic heart disease, maybe COPD, then they fall, break a hip, and die a few weeks later from complications.
Perfect example.
What's the principal cause? The heart disease, the COPD, the fracture, the post-op infection. If the study doesn't clearly state its logic for picking one,
how can anyone else replicate that decision? How can you compare it fairly to another study that might have different implicit rules?
it's impossible. You can't follow their reasoning.
And that's precisely why the authors concluded that none of those 12 general studies were repeatable.
Wow. None of them.
A critical finding. It means a big chunk of the research evaluating general death certificate accuracy was methodologically pretty unsound.
Okay, but what about the studies focusing on a specific condition, like asthma or cancer? You'd think maybe that would be clearer cut.
You'd hope so, but issues persisted there too. Out of the 32 studies focusing on specific conditions, only 21 actually provided explicit diagnostic criteria.
So almost a third didn't even clearly define the condition they were supposedly evaluating.
Exactly, and it gets worse. Of the 16 studies that did at least discuss the difference between a principal cause and just a contributing cause,
Yeah.
only 8 described how they actually identified that principal cause in complex cases. Just 8. And hold on, for those 8 studies that did describe their selection strategy, here's another major red flag.
Oh boy.
In 3 of them, the strategy they described actually conflicted with the international instructions from the WHO, the official ICD coding conventions.
Wait, what? They used different rules.
Yes. And in 2 other cases, the specific classification examples they provided also contradicted the official ICD rules.
So let me get this straight. Studies trying to evaluate the accuracy of death certificates, which are supposed to follow WHO rules, were sometimes using different rules themselves. and often not even mentioning it.
That's exactly what they found.
It's like trying to referee a basketball game using soccer rules and just hoping nobody notices.
Hey, yeah, that's a pretty good analogy. They rarely pointed this out or discussed why they weren't applying the international conventions. This means different studies might be operating with entirely different rule books to decide what ultimately killed someone.
Making their conclusions basically incomparable.
And potentially very misleading, especially if we're trying to build a coherent global picture of mortality. If the evaluation method itself deviates from the standard it's supposed to be upholding, well, its findings become highly suspect, don't they?
Yeah, this whole situation really makes you question the foundation. If these evaluation studies aren't clear about their methods, and some even contradict the international standards they should be measuring against, how can we actually trust their conclusions about death certificate accuracy?
We really can't. Not without significant caveats, anyway. And that's the powerful central message of this Johansson paper.
So, okay, let's bring this back to us, the listener. Why should you care about these, methodological flaws in studies evaluating death certificates? This isn't just some academic squabble, is it?
No, absolutely not. It's far from it. The implications are genuinely far-reaching. Many of these evaluation studies, as the paper points out, are actually assessing how well the data suits a particular purpose they have in mind.
Like what?
Like, say, estimating the prevalence of a specific condition that was present at the time of death. But that's subtly different from verifying whether the single underlying cause of death was correctly reported according to those strict official ICD standards. And that distinction is absolutely critical because official mortality statistics, the ones used to guide so much public health work, resource allocation, policy, are based entirely on identifying that single underlying cause.
It reminds me of the drowning example the paper gives, which really clarifies it. The cause of death, asphyxia, or inability to swim, or the fall into the water, or maybe insufficient fencing around the pool, or even the hot weather leading someone to swim.
Right.
Official statistics need to narrow that chain of events down to one underlying cause for consistency and comparability across time and place.
Exactly. And if the evaluators in these studies aren't consistently applying the same globally recognized rules to determine that single underlying cause, well, their findings can seriously distort our understanding.
So you could end up, pouring millions into a heart disease prevention program based on skewed data, while the real unaddressed crisis is maybe something else entirely, like undiagnosed respiratory illness.
That's precisely the kind of real-world consequence. Misallocated resources, flawed public health priorities. It's the potential human cost of these methodological gaps. Because if the evaluation studies themselves are flawed, if their methods aren't transparent or reproducible, then the conclusions drawn from them become unreliable. Whether you're talking about disease prevalence or the effectiveness of public health interventions, or even tracking treatment outcomes, it all gets shaky.
Leading to bad decisions.
Potentially, yes. Flawed research builds on flawed foundations, and you end up with an inaccurate picture of public health, which ultimately has real detrimental impacts on people's lives.
The authors even bring in that powerful quote from Tunstall Peto, saying that death certification practices often retain an unfortunate and undeserved 19th century aura of professional inviolability,
which antedates modern concepts of quality control, audit, and accountability. Yeah, it's a striking quote.
It really is.
And it connects to the bigger picture here perfectly. It means the very systems designed to ensure accuracy sometimes lack that crucial quality control themselves. Transparency and reproducibility aren't just, academic buzzwords. They're fundamental hallmarks of sound scientific work.
And they were often missing here.
Glaringly missing in many cases. Explicit descriptions of methods, clear criteria, these are absolutely essential, not just for improving the methodologies over time or increasing comparability between studies, but also for allowing you, the reader, the policymaker, the concerned citizen, to properly assess how generalizable, how trustworthy any study's conclusions actually are.
So we've seen today how even these crucial studies, the ones meant to ensure the accuracy of something as basic as cause of death data, can suffer from pretty significant methodological gaps, especially around consistently defining and identifying that all-important principal cause. It really highlights that even in fields that seem robust and scientific, taking a deeper look at the methods, how the work was actually done, can reveal crucial insights that reshape our entire understanding.
And maybe this raises an important question for you to consider long after you're done listening. When we rely on statistics, whether it's in medicine, public health, maybe even economic reports, how often do we really scrutinize the methods used to gather and validate that data? Not just the headline numbers, but the process behind them.
That's a great question. And what deeper questions should we be asking when we encounter conflicting results in research that seems, on the surface, authoritative? Definitely something to chew on. Until next time, keep digging, keep questioning, and stay well informed.